My name's Grace Pearson. I'm a specialty doctor in geriatrics in Bath and a very fresh clinical lecturer in ageing education at Bristol Medical School. But thank you very much for inviting me here today to talk about my Dunhill Medical Trust funded PhD fellowship. So I probably don't need to tell you in this room that the population is ageing, and it's considered one of the 4 global demographic megatrends. Globally, there were 703 million people aged 65 and over in 2019, and this is projected to double to 1.5 billion by 2050. So put another way, by 2050, 1 in 6 people in the world will be over 65 years old. And here in the UK, the 2021 census documented 10.4 million people aged 65 and over, and that's a 52% increase since the 1981 census, which is projected to increase by a further 32% over the next 20 years. And this has an inevitable impact on health and social care, as older people are the most frequent users of healthcare, accounting for over 40% of hospital admissions, and they have longer, more complex stays in hospital, occupying 2/3 of inpatient beds. And yet, there's only 1 consultant geriatrician per 8,000 people over 65 in the UK. And this workforce insufficiency, combined with a ubiquitous ageism, has led to catastrophic effects on quality of care and has contributed to the current crisis of care that we have for older people. In their international Teaching Geriatrics in Medical Education studies, the World Health Organization found that high-quality education in geriatric medicine at an undergraduate level improved medical students' attitudes towards old people, in turn making them more likely to consider a career as a specialist geriatrician. And it follows, therefore, that undergraduate medical education has the power to combat ageism in healthcare and enhance the specialty workforce, thus improving the care of older people. And this fundamental importance of education and training is recognised by the NIHR in their research priorities and by NHS England in their workforce plan. Yet, currently not every medical school in the UK teaches geriatrics. And where they do, it's typically only for 49 to 56 hours of a 4 to 6 year degree. And that's simply because there's a lack of evidence for best practice in the field. And as we know, evidence drives policy, and therefore my PhD fellowship sought to fill this evidence gap by establishing a blueprint for best practice in undergraduate geriatrics education to ensure that the entire future workforce are equipped with the knowledge and skills to care for our ageing population in whatever their chosen specialty. So locally, my work centred around innovation and evaluation of the complex medicine in older people curriculum at Bristol Medical School, also known as CMOP. And this is a unique 18-week clerkship in geriatrics, palliative care and complex general internal medicine for 4th-year Bristol Medical students. And part of my PhD fellowship has been to innovate this curriculum with novel tutorials such as ward round simulation, immersive inclusion of the humanities with a book club, and integration of successful community outreach events. And the other part of my PhD fellowship has been to evaluate this curriculum transformation, which was from just 4 weeks of geriatrics in the old curriculum to this new 18-week programme. And in my thesis, I compare 3 short-term outcomes between the 2 curricula, but also longitudinally across the 18 weeks of CMOP. And these outcomes are attitudes towards older people by means of the ageing semantic differential, their empathy using the Jefferson scale of empathy, and their career intentions. And I found that CMOP successfully improved Bristol students' attitudes towards older people, particularly with respect to their functionality and instrumentality. And I also found that CMOP increased my students' likelihood of considering a future career in geriatrics from just 6 to 17%. In addition, I led nationally a curriculum survey of UK medical schools about current teaching provision in geriatrics and led a team from the BGS to update their recommended national curriculum. And all of my presentations and publications can be found using that QR code, which leads to my University of Bristol research profile. So what next? Over the next 1 to 2 years, I will publish the results from my thesis, and those are the short-term outcomes that I've outlined for you. I also have consent to follow up my students who have graduated to evaluate the impact of curriculum transformation on longer term outcomes, which might be the results of nationally collected surveys by the GMC, for example. There's also a wealth of opportunity to further innovate the CMOP curriculum, and particularly I see opportunities in palliative care, in interprofessional education and in patient public outreach. I'll also publish the results of our National Curriculum Survey, giving exemplar models of teaching for institutions seeking to implement the updated BGS curriculum and align their teaching with new General Medical Council requirements. And that will be done in collaboration with a network of educators and researchers working in this field, which I've helped to establish through my work with the BGS. And I've also received approval from the UK Medical Education Database to link the results of this National Curriculum Survey to specialty recruitment data, to robustly evaluate what impact differing undergraduate teaching in geriatrics has on recruitment to our specialty. And internationally, I've been invited by the European Geriatric Medicine Society to sit on a panel to update their recommended undergraduate curriculum, and also work on their programming project, which is promoting geriatrics in countries where it is emerging. And that's in a working group surveying current undergraduate teaching provision across Europe. And that's what the QR code on this slide is for. If any of you are teachers or medical students, you could fill in that survey, that would be great. And just want to say thank you to Dunhill, because by networking at conferences during my PhD, I've made connections with educators and researchers working in Africa, working in the United States and New Zealand, all with potential for future collaboration. So thank you for listening.
So we have time for some questions. So any questions from the floor? We have some roving mics as well, so if you can just wait till the mics are with you. Any questions? Okay, one here. While we're waiting for the mic, I thought I might ask, could you give some specific examples of how, say, some aspects of undergraduate teaching can combat ageism?
Yeah, so there's evidence to show that specifically experiential teaching, so using simulation or simply clinical attachments, is really important in combating ageism. Because we know that there's a lot of negative preconceptions out there, not only about older people, but also about geriatric medicine. So giving them a positive experiential environment, whether through simulation or clinical attachment, is important. But also empathy building interventions, which again includes simulation, role play, and kind of pairing, long-term pairing of patients with students is really helpful as well. And I can't understate the importance of role models as well. So having 18 weeks with a really positive role model in geriatrics has been effective in improving our students' attitudes towards geriatrics and willingness to consider it as a career.
Thank you for that, Grace. That's really helpful. Sue.
Hi, Grace. Good to have you here. I'm just really interested because the University of Bristol were really market leading, if you like, in changing the curriculum. Are you getting any sense of other universities interested in taking this up?
Yeah, so we've been contacted by lots of universities who want to take elements of CMOP. And the way we designed the curriculum means that that is possible. There was a lot of optimism from the BGS and other organisations that the change in GMC requirements, so the GMC is the General Medical Council, they regulate all UK doctors, but they also regulate education and training, including undergraduate education. They've recently changed their requirements, and that they expanded the remit of geriatrics within those requirements. And there was a sense of optimism that that would help, and that medical schools would suddenly stand up and change everything. That hasn't happened. There's a major difference we're finding between offering guidance and changing requirements to actual implementation. And medical schools can very easily map geriatric medicine to elements of general medicine throughout their entire course without actually affecting positive experiences for medical students in geriatrics specifically.
That's really interesting. So still some work to do then.
Definitely.
Thank you very much for that. Any other questions? Carmel.
Thanks very much for a really interesting presentation, Grace. You mentioned about the role of humanities and a book club. Can you give us a little bit more detail about that, how it works and the types of books that students are reading and what they do with that?
Yeah, so it's been difficult to engage students with it, I'm not going to lie, but it's been a really, really good way to improve kind of staff and student, reduce that hierarchy and improve engagement between staff and students. We give them a list of, I think it's 6 non-fiction and 6 fiction. They get to choose, they can read as many or as few as they like, and then they arrange the meetings themselves, and that includes staff as well, to discuss those books. And really reflect on how those books are going to change their own practice. That's supplemented by, so I've done interviews with lots of the authors of these books, so they can watch those interviews and really see what the author wanted the reader, as future clinicians, to get out of reading their books. So yeah, that's primarily how it works.
Thank you.
Thank you very much, Grace. Any other questions before we tie up? Oh yeah, one here, Gordon.
Hi. It's obviously very well known that the medical course is very intense as it is. So when you're changing the curriculum to add in an 18-week programme, how do you then develop the course to take out other things or replace things and things? There's a lot of things in that, sorry.
Yeah, so it's a constant battle is the answer with the medical school. We got CMOP, we got 18 weeks for CMOP because we argued that even if they're not going to become specialist geriatricians, all of the graduates will have to care for older people, whether that be in surgery, cardiology, whatever they go into. And so we argued that the proportion of the curriculum should reflect the proportion of the population that the graduates will serve. And that worked for us. It doesn't work at other medical schools. And it kind of comes back to that advocacy and the importance of actually having really strong academic geriatrics and ageing research at the medical school. There's a link between presence of faculty members and the quality of undergraduate education in that area. So that's, potentially, because my supervisors are amazing, maybe that's why we got 18 weeks, but also I think there's an increasing drive for the curricula to really represent the population demographics as well.
Thank you.
Well, thank you very much, everyone. Great questions, and thank you, Grace, as well.